Good morning and welcome everybody to my lecture session on pulmonary hypertension. Now, to continue, preoperative evaluation. Patients with pulmonary hypertension are at high risk patients who should be evaluated by a pulmonary hypertension specialist before surgery and should be started on appropriate medication as indicated. The goal of the pre-op evaluation is to determine if the patient suffers from pulmonary hypertension, right ventricular failure, or a combination of these, as this knowledge affects the management. Now, clinical findings, the signs of PH, as pulmonary hypertension, are often vague, but the most common sign is dyspnea with exertion. This symptom can progress to dyspnea at rest, chest pain, fatigue, and syncope. A history of syncope is an extremely poor prognostic sign. The etiology of the PH should be determined if possible, and a cardiac echocardiographic exam should be obtained. Valvular structures, size and function of both the RV and LV, and the presence of any intracardiac shunt should be evaluated. Echocardiography can measure the mean pulmonary arterial pressure. However, this is often underestimated. Therefore, cardiac catheterization is the gold standard of measure. Pulmonary vascular reactivity can also be determined at catheterization to test the responsiveness to vasodilators. Medications. Common medications for the treatment of PH include calcium channel blockers, digoxin, diuretics, prostaglandin infusion, and sildenafil. Patients with PH are often taking warfarin, and they should be transitioned to low molecular weight heparin. Pulmonary hypertension medication should be continued, and doses should not be missed on the day of the surgery. A complete blood count, metabolic panel, coagulation panel should be evaluated. Consider pre-op blood gas analysis. An ECG should be performed to evaluate the signs of ischemia or right-sided ventricular strain. Anesthetic management. Type of anesthetic. Regional anesthesia is likely the best approach for the pulmonary hypertension patients if possible. Peripheral nerve block or epidural, but not spinal anesthesia, although data is limited and retrospective in nature. It was shown that operative mortality in patients with Eisenmenger's syndrome was 18% with general anesthesia versus 5% with regional anesthesia. Conversely, a review of obstetric outcomes over 18 years demonstrated the similar outcomes using either general or regional anesthesia. For moderate to severe pulmonary hypertension, spinal anesthesia is contraindicated due to chance for abrupt alteration in systemic vascular resistance and pre-roll. Maintain the preoperative medications and continue for the prostaglandin infusion, as even brief infusion interruptions can cause rapid deterioration and death. For patients taking sildenafil, avoid nitroglycerin and nitroprusside, which can cause severe hypotension. Outpatient therapy is typically titrated slowly and carefully, so it is critical that this is not disrupted for elective surgery. Monitoring. The arterial lines are indicated for all but the lowest risk surgeries. Central venous access. Caution should be taken during placement to avoid inducing arrhythmias. If atrial arrhythmias develop, cardioversion will avoid the rapid cardiovascular collapse that can occur. Pulmonary arterial catheter. That the information gained by this monitor may provide critical information for ventilatory and inotropic management, making it recommended for most intermediate and all high-risk procedures. Caution must be used when inserting a pulmonary arterial catheter, which may be more difficult to place in a pulmonary hypertension patient. Thank you. This brings me to the end of this lecture session. I will come up with the rest in the next video.